We are delighted to have with us Dr. Terence Keane. Actually, this is kind of a homecoming because he just told me he was born in the Bronx. Dr. Keane is the Director of Behavioral Science Division at the National Center for PTSD in Boston. He's Professor of Psychiatry and Psychology at the Boston University School of Medicine and serves as the Vice Chair of Psychiatry and Assistant Dean for Research. And since he wasn't very busy, I thought I would ask him to stop by and give us a talk. He is a world leader in the field of traumatic stress. He's developed some of the most widely used PTSD instruments that are available, including the CAPS-5 for the DSM-5, Mississippi Scale for combat-related PTSD, the Keane Scale for the MMPI, Combat Exposure Scale, and the Post-Traumatic Stress Disorder Checklist, now Checklist 5, adapted for the DSM-5 criteria. Dr. Keane's expertise also includes cognitive behavioral treatment of PTSD. He is a frequent reviewer for NIH grant proposals and served as the co-chair for the NIMH Consensus Conference that established the national standards for PTSD diagnosis and assessment. Dr. Keane has over 300 publications and has presented over 400 times at national or international conferences. He's on the editorial board of 7 journals. His research has been continuously funded for 33 years by federal agencies such as the National Institutes of Health. He's the past president of the International Society for Traumatic Stress Studies, Division 56 of Psychological Trauma at the APA, the Anxiety and Depression Association of America, and is now president of Division 12 Clinical Psychology of APA. He's a fellow of APA and APS. Dr. Keane has received numerous Lifetime Achievement Awards, for example, from the International Society of Traumatic Stress Studies, and Division 12's Outstanding Research Contributions Award from the APA, and recipient of 2 honorary doctorates for his work in post-traumatic stress disorder. We're delighted that he's here to present today for his talk called Assessing Psychological Trauma and PTSD, Recent Updates for DSM-5. Welcome.
Well, it is a pleasure for me to be here. I want to thank John for the invitation to come meet with this group and to share with you some of the activities that we've been up to here lately. I want to begin by saying that I've had a unique perspective on the evaluation and the assessment and the diagnosis of psychological trauma because I began work in this area in 1977, 1978, when there really wasn't much information available about psychological trauma in the scientific or even the clinical literature, frankly. And it was my background and experience in the addictions that ultimately led me to the observation that many of these people who were coming forward with very significant alcohol and drug use abuse shared in common symptoms and experiences that we now know as psychological trauma. In 1977 and 1978, I was an intern at the University of Mississippi Medical Center. My intention was to study the addictions. My graduate degree was from the State University of New York in Binghamton, New York, and I had an interest in anxiety disorders as well while training there. And it was really the blending of the preparation and training that I got at the State University of New York that really allowed me to make some of the observations very early on about the issues of psychological trauma and the addictions. I want to also just highlight for you that the internet did not exist in 1978, at least as far as I know. And the truth of the matter was that it was very hard to find information about trauma. It was very difficult. And what I used to do was every time I took a trip anywhere, somewhere, some city of any size, I would go to libraries, I would go to bookstores and try to find information about this whole issue. You didn't know who was interested in this topic at that time, and there were no meetings. The International Society for Traumatic Stress Studies was established in 1985 with its first meeting in 1986. So for years, literally years, people were basically working in isolation with very little information about what one another was doing and what we're seeing. Of course, my focus has been on combat and on combat-related trauma and combat-related PTSD. But at the same time, there were people studying sexual assault and rape. There were people studying child abuse. There were people studying industrial accidents, all studying, in my view, the same elephant, but holding on to a different part of that elephant. And it was really only through meetings at the American Psychological Association, at the Association for Behavioral and Cognitive Therapies, and a variety of places where there began to emerge discussions and conversations about the issues of psychological trauma, and using those very terms. In 1985, I had the great and good fortune to move from the University of Mississippi Medical Center to Boston, where I met a large group of like-minded people who were interested in studying psychological trauma from all vantage points. And it was through that group, and I will tell you that there would be 25 people meeting in my living room or Nina Murray's living room or Bessel van der Kolk's living room every month. And we would invite speakers from all over the world. And they would come to meet with us and to share what their observations were about psychological trauma. But it was in this sort of vacuum of information in the late 70s that I became interested in the scientific study of psychological trauma. And while the name PTSD was provided by the DSM in 1980, I was referring to these problems as the Vietnam stress syndrome. Seems somewhat quaint today and sort of very microscopic in nature, but I was really glad to see this much more broader rubric that tied together all of the people doing this work. And it was from this sort of interest of mine in trying to understand these patients and these people who were coming forward in increasingly large numbers as they understood that there was somebody there at the VA hospital in Jackson, Mississippi, who was interested in understanding the impact of the war on their psychological adjustment. It was at that time that we began the process of trying to develop a number of different psychological tests, and John has sort of listed off several of the ones that our group had a hand in developing, examining, and evaluating. But I do want to say that in these 35 to 40 years that I've been doing this almost exclusively, I think it was 1982 when I stopped taking patients who didn't have an experience of trauma. It was through all of this work that I think the field of PTSD has simply exploded on the scene. And those of you who are in clinical practice in corners like Coolidge Corner around the corner from my house know that in your practice there will be a substantial number of people whose life experiences have included one form or another of traumatic life experiences. And it is, I think, because of the frequency of these experiences that there continues to be a remarkable generative interest in studying the impact of life events on adjustment and future life goals, objectives, and adjustment. So let me begin by saying that it was very hard for me to figure out exactly what to talk about here today. There is so much now. The field is so broad. But I do want to say that within eye and earshot of here, this was basically, coming from Boston, the shot heard round the world for the field of psychological trauma. It is when the World Trade Center was attacked, when America was attacked by terrorists, that the entire country Psychologists, psychiatrists, social workers, notwithstanding, the entire country began to use the term PTSD. Everyone understood it as a function of this set of experiences. And from my vantage point, this, of course, led to the development of a whole new generation, approaching some 3 million Americans who have served in very active, very intense war zones on our behalf. These new veterans are suffering from a considerable amount of trouble at the present time. I think the problems can be encapsulated with a shorthand term of post-deployment psychological health problems, to incorporate things like PTSD, substance abuse, depression, this mild traumatic brain injury which may or may not yield chronic traumatic encephalopathy, or this condition that Ann McKee, my colleague at VA Boston, identified several years ago that comes from shatters to the head. The good news here is that despite what you may have heard a year ago about some of the problems in access to care in the Phoenix VA Medical Center, the Department of Veterans Affairs Veterans Health Administration is among the very finest healthcare delivery systems in all of America. And I put it up there, and as do many other people, with the likes of Kaiser Permanente, Geisinger, Mayo Clinic, and the like. This is largely attributable to the incredible emphasis on research in our patient population that VA has, this stunning electronic medical record that we have that allows us to understand patients when they come in the door, if they've been seen in Los Angeles, Boston, San Francisco, or Miami Beach. We can understand what has happened to them through this electronic medical record. It is the envy of everyone in the country today. I do want to start by saying that although my focus will be, not surprisingly, on combat-related PTSD, and combat-related PTSD in the very large patient population that I work with, PTSD is a global problem. I can say that definitively. 25 years ago, I was invited to London because I had published a few papers early in my career, and I thought this would be a great opportunity for me to figure out what they've learned. Well, it was the zeitgeist at the time in London to see PTSD as a uniquely American or /Western set of problems. What I've assembled for you here on this slide is really, I think, a more comprehensive understanding of trauma exposure and PTSD. And the interesting part about this slide is that it does make some sense in some ways. The sole exception that doesn't make any sense to me or virtually anybody else is why the country of Germany would have such a low prevalence rate of PTSD at about 1%. Has anyone ever driven on the Autobahn alone? It is the case that America suffers greatly. About 8% of the general population will develop PTSD at some point in their life. These are findings that have been replicated multiple times by multiple groups of people, most recently by Ron Kessler's National Comorbidity Survey replication. But if you look at these other countries, very different from the West in terms of language and culture and sort of acceptance of psychological mindedness, you see Ethiopia, a country that has been racked by civil war, prevalence rates of 15%, 16%. Cambodia, we all know about the killing fields. Remarkable numbers, 28% of the adult population have PTSD. More recently, we've come to learn and to appreciate that this is now being handed down to the next generation, not necessarily in the form of PTSD, but in the manifestation of all kinds of problems, behavioral problems, that you can understand might occur if you had a mother, father, or both who had post-traumatic stress disorder and all the dysregulation in emotion and emotional responsivity for people with PTSD. You leave Cambodia and then you go to Algeria. And in Algeria, of course, there was a terrible civil war in the late 90s, mid to late 90s, where neighbor was fighting against neighbor, much like what's happening in other parts of the Arab world today. And the prevalence rate there, 37%. Now, these are not numbers that are just plucked out of nowhere. These are from some of the premier psychiatric epidemiologists in all of the world. Joop de Jong in Amsterdam, Ron Kessler, of course, at Harvard, Perkening et al. From Thailand, who's was a refugee, I believe, to Sweden. So PTSD is by all counts an international problem. It is not a Western thing. And of course, to me, that suggests that there must be some kind of biologic, physiologic, and psychologic underpinnings to this condition. So let's talk quickly about the evolution of the PTSD diagnosis. PTSD was introduced in 1980, as everybody here certainly knows. It was from DSM-3 to DSM-3R, which was a group of people, myself included at the time, remarkably enough, who was studying PTSD. And it was from 3 to 3R, which really went on for about 2 years, from about 1984 to 1986. Lots of meetings, lots of debate, lots of data being discussed. This is where many of the changes actually occurred. It went from 12 symptoms to 17 symptoms. The introduction changed fairly dramatically. The background information all changed dramatically. But what happened here was, I think, a contribution of Betsy Brett, my colleague now at New Haven and Yale, suggested this very much of a psychodynamic concept of re-experiencing avoidance and numbing and hyperarousal as the best way, the primary way of collecting these symptoms together in a rubric. It also was the case that guilt was dropped, and I must tell you that guilt is omnipresent in PTSD, and I was among the people who was arguing for it to be dropped, the problem being guilt does not discriminate one psychiatric condition from another, to be honest, and the purpose of psychiatric nomenclature and items and within is to discriminate one syndrome from another, and guilt is pretty much across the board. The DSM-3R went then next to the DSM-4 some 10 years later. Criterion A was extensively reworked, revisited, and of course we came up with the bifurcated Criterion A, which was an exposure is necessary, of course, but the response was necessary too. But I need to tell you today that because this has now changed, it was always viewed as an experiment, whether you needed both. As it turned out, Frank Weathers, myself, and a host of other people subsequently looked at data suggesting you didn't really need both. It didn't add much at all to the accuracy of the diagnosis. And so we now just simply have exposure as the lead-in to the diagnostic criteria. And I think the other aspects of this, minor details, physiological reactivity, something that I spent a great deal of time with early in my career, was moved from the hyperarousal symptoms to the re-experiencing symptoms. Why? Because it hung there empirically when people were answering many questions about their symptomatology. The re-experiencing phenomenon and the physiological reactivity of cues resembling the traumatic event all seemed to hang together very, very tightly. And the good news was it wasn't just in the combat veteran data that I presented. It was across many different populations, and so this change occurred. And I say this only because of the importance that data from the science informing, well, at least it's good music, informing the process of creating the diagnostic criteria. Let me just go to this next slide here, which I think presents for you the current iteration, or the DSM-5. And this was actually a very interesting experience. I also served on this committee, although I had a more minor role this time through than I did in the past. And so you have these intrusive thoughts, you have these avoidance thoughts, the sort of pushing and pulling, as Betsy Brett would have suggested, and the negative alterations in mood and cognition. So Patricia Resick and Chris Bruin, two very cognitively oriented psychologists, really ruled the day on this and suggested that this was a very important thing in their experiences to incorporate into the diagnostic criteria. And then, of course, the indices of arousal, hyperarousal, reactivity, et cetera. These now are the core features of PTSD as they were. What drove this four sort of factor component here in PTSD, for PTSD, was the fact that there were many confirmatory factor analytic studies, scientific studies across so many populations that found 4 factors rather than the 3 that had been in DSM-3, 3R, and 4. So we said, well, you know, it really seems to be all falling out pretty naturally into 4 different clusters or factors. We should really try to label these things and use what the science is telling us. Now, of course, we are now, I think I have either reviewed or read about 9 studies doing factor analyses of these symptoms. We went from 17 to 20. And there are now 5 or 6 factors that are popping out, and it's pretty consistent across populations too. It may be a function of the way in which we're entering the data. That's maybe a function of the way in which people are responding. It could be a function of the way in which people are experiencing their psychological trauma. It's not clear to me, nor is it clear to too many people. I'll tell you just quickly that when I first began the work in this field in combat veterans, there were no measures. There were no measures. And we set out to try to develop measures. Some of them John has very graciously identified. But it was really, the changing point really was in the National Vietnam Veterans Readjustment Study. For the entire field, even though it was on veterans, this had a major impact, broadly speaking. Because one of the things that they recognized in 1983, as they were getting started in this project to examine the impact of the Vietnam War on the people who fought there, what they realized is that there were no real sound measurements. We had developed at this point the Mississippi scale. We were collecting data on it. We had some preliminary data. At the end of the day, the Mississippi scale was validated both in this NVVRS study, its preliminary study, but then subsequently as the most powerful predictor of who did and who didn't have PTSD. I'll just add for you now, and we'll go on from here, that a 25-year follow-up of these veterans, the very same veterans, was just completed within the past year. And once again, the Mississippi scale, which had very high content validity, great sampling across all of the symptoms of the condition, and was not tied to the diagnosis, but high content validity. It once again was the strongest measure of PTSD in this study conducted 25 years hence. In the last 20 years, there have been so many studies, it would be impossible to give a review of it coherent. It would be impossible to write a coherent review in less than 100 pages of what has happened in the assessment of psychological trauma and in the assessment of PTSD. And I can say that there are many instruments, some of them developed by our group, some of them developed by many people in this room, that have contributed greatly to our knowledge. And every time I go in to look carefully at the normative and standardization material, what I'm left with is there's a great deal of similarity across all of these measures, and they're all pretty darn good. So if you just take a good look at the norms and the standards, the approaches that people have used, they really are good. And it actually begs the question of, well, geez, this is such a complicated matter. How do we measure this? And how can we measure? And how can it be coherent if there are so many symptoms? My response to that is, if we can have as many measures that have as high a high rate of reliability and validity against diagnostic information, we have a relatively coherent syndrome that is now known as PTSD, and that syndrome is very, very coherent. It's our measures that are kind of off a little bit, but nonetheless, they are all strong, and I'll give you a few examples of this here. Before I say more about the actual instrumentation here, I did want to, it's here. I did want to show this slide here because it demonstrates the complexity of the situation in which we find ourselves currently in Veterans Health Administration. It is the case that the three most common, if you will, psychological health problems are chronic pain, post-traumatic stress disorder, and mild traumatic brain injury or post-concussive syndrome. These are the three big ones. We could argue substance abuse, we could argue depression. These are the three that we chose. But the point here is that within the center of the Venn diagram here, it suggests that 2 out of 5 of the patients have all three. And virtually all of them have 2 of 3. And that, to me, actually represents a major challenge to the whole notion of measuring PTSD, because we are now measuring PTSD clearly in the context of other psychological health conditions. And we have to keep this in mind as we proceed through developing, examining, and validating these instruments. So, going back, I think dating back to among the very first articles that we wrote, this was in Journal of Consulting and Clinical Psychology in 1982, we talked about the importance of multiple measures, multiple methods of going about measuring PTSD. And as I also alluded to earlier, I was very interested in psychophysiological reactivity initially. Why was I interested in it? Because these patients coming into treatment exhibited behavioral manifestations of physiological reactivity. And it was then that we began to use psychophysiology to, I think, great effect in understanding people's physical response to cues of trauma. But as well, we talked immediately on about a clinical diagnostic interview. We developed something that was called the Jackson, Mississippi, Jackson Structured Interview for PTSD in about 1980 and 81. And that became the clear predecessor for the SCID, which was developed by Janet Williams and Bob Spitzer and Michael First at Columbia. But it was the Jackson that led to the development of the SCID's PTSD module. And then as well, the whole notion of psychological testing, which we've had a major commitment to. First, for reasons that really date to my training, the use of the Minnesota Multiphasic Personality Inventory, and then subsequently our interest in developing a particular test for a PTSD within the existing items of the MMPI. There are, let me just say, many other approaches to personality assessment. I actually encourage my trainees and my research center to use personality measures for all the reasons that this group surely knows. But for whatever reason, it's the use of the MMPI, the use of the PAI, another terrific measure of the Milan, has fallen into disfavor, I guess, in the graduate training programs. Because even though I make them do these things, once they're on faculty, they don't seem to want to incorporate these measures into their programs or into their research for reasons I don't fully understand. But the point here is that even when you draw from these different vectors of information, all of them are individually imperfect. and they require clinical judgment in their use. Now, again, this is sort of simplistic for this group to hear, but it's always been my position that even if we had a biological marker for PTSD, biomarkers, this is the rage today, even if we had a biomarker, it's going to have sensitivity and specificity. It's going to have false positives. It's going to have false negatives. And there is never going to be, if you will, the silver bullet or the litmus test for identifying people with PTSD. I do not believe, although there would be people who would argue with me. The Jackson structured interview led to the SCID. The SCID, as most of you know if you use it, the structured clinical interview for the DSM, is basically a yes/no score. That never sat very well with me because I always viewed these conditions or the symptoms within this condition as a dimensional idea, and that to simply try to categorize it as yes or no always seemed a struggle or a stretch to me. We developed, back beginning in 1989 when the National Center was first funded, we, Frank Weathers and I, developed something called the Clinician Administered PTSD Scale. Frank was his first year out of internship, and I basically turned over the CAPS to him, and 25 years later, Frank is one of the premier psychometricians and diagnosticians in the field of PTSD today, working at Auburn University, but still working with us very closely in the updates of the CAPS and the PTSD checklist and the like. So the CAPS is a clinician-administered PTSD scale. It is really the gold standard today for PTSD. There are other, as I said, there are other measures that are every bit as good, frankly. But it's really what people are using to make the structured interview diagnosis of PTSD. I do want to be clear right at the beginning of this part of the lecture that I'm totally committed to functional analyses of patients. So while diagnosis is important and assessment of outcomes is important and assessment of process variables is really important, at the end of the day, when you're sitting in a room with a patient who's asking you to try to help them some, it's really about trying to identify what it is that they can do with the resources that they have, and what the limitations that they have, and how you can go about remediating them. And this actually comes from, sort of my background and my training. It is in the it comes from the behavior analytic world. And here's like, what are the patient's strengths, assets, their advantages, and similarly, what are their limitations? What are their weaknesses? What are their complaints and problems? And it's this kind of functional analysis in conjunction with the diagnostic material that you assemble that I think helps you come up with what the recommendations would be in any kind of a diagnostic or assessment report that you might make. To do one or the other, I think, is actually limiting for trying to provide feedback to patients about what they might be able to do to improve their situation. To do both concurrently, while it's not that easy, but to do both concurrently is an important first step in helping people in the process of recovery from trauma. So as I said a little bit ago, the SCID PTSD module is one of the diagnostic interviews, but there are many others here. I've listed them there for you. These are all very good tools, frankly. When you think about PTSD, you think about immediately comorbidity. There are very few cases of PTSD coming for help, coming into your office or your clinic that have only PTSD. I must say that. They often carry, they travel in cohorts. It's PTSD, it's depression, it's sometimes other anxiety disorders like panic, sometimes substance abuse problems, but it can be a wide array. And so trying to examine people thoroughly really requires something like the structured clinical interview, the SCID, developed by the folks at Columbia. And there are a wide range of PTSD self-report measures that I can recommend to you. And again, I will say that we developed the PTSD checklist, and we're committed to it. And it has been used in, I think the number was about 3,000 studies to date. These others actually are every bit as good. They cover the same dimensions. The thing about all of these self-report scales is they reference back to the diagnostic criteria, which I think of as kind of not so great. And it's why I think I have been, and I have remained a fan of the Mississippi scale and of the MMBI, because it doesn't reference back to a diagnosis and specifically to the diagnostic criteria is what I mean to say. It actually tries to get at the construct, the higher order construct of psychological trauma and its response. And the Mississippi scale continues to do well, no matter what patient group, no matter what veteran cohort we utilize it with. PTSD self-report measures, they can vary by correspondence with the DSM, the time framework assessed, last day, last week, last month, last 3 months, last 6 months. The dimensions in which they evaluate people, and all of these things are choice points that you have in selecting instruments for your practice. I would say that this last iteration of updating all of our diagnostic criteria-related measures was the most challenging to try to get everybody to agree on the wording. In the earlier iterations, I was like really the senior guy, and I would just say, well, let's just say it this way, and that would be taken as sort of gospel. No longer is that the case. Others have much greater influence in the actual wording, and they're probably far more experienced than I in so many ways. I've talked about the issues of personality assessment. Who's going to do well in therapy? Who is going to accept certain kinds of therapies, for example, a cognitive approach or an emotional approach like the exposure therapies? Paul Arbisi from Minneapolis, VA, has done a great deal of work in this area, and this is a really relevant part of things that I hope does not get lost in the current climate of sort of this tendency to rapid assessment that is, I think, predominating in our field and our profession today. So who develops PTSD? Well, the meta-analyses data are pretty strong, and it's basically about how much trauma do you experience. At the end of the day, how much, how frequent, how often, what the inter-trauma interval is. Did you hear that R at the end of trauma? That was my New York speaking. The inter-trauma interval. Other life stressors, adverse childhood events, low socioeconomic status, intelligence, education, which I think of as code for the ability to problem solve or to bring resources to bear on problem solving difficult situations. And then finally, we know that gender has been linked to both trauma exposure and to the development of PTSD. In the instance of trauma exposure, men are more likely to be exposed. In the interest of psychological trauma, PTSD, the response, women are more likely to develop PTSD upon exposure. These are things that we don't fully or completely understand, and it may be linked to the biology, it may be linked to same issues of gender that pervade the anxiety disorders and even depression. And that may have a lot to do with the role with which that women assume in our society. I did want to say a couple of things here because I think this encapsulates my thinking about issues of psychological trauma and PTSD. I think of exposure as a dimensional variable. I think of PTSD as a condition that is also dimensional. My friends and colleagues, Dan and Linda King at the National Center for PTSD, conducted a very extensive evaluation with data from the National Vietnam Veterans Readjustment Study. And they looked at the pre-war factors, the post-war factors, and the war zone stressors in trying to predict out who would go on to develop PTSD. The powerful finding that came from this very elegant series of studies that they did with this remarkable data set, suggested that war zone stressors was responsible for the bulk of the symptomatology that was observed 15 to 20 years later. But it was not unique to war zone stressors. There were major factors in pre-war area, and there were major factors in post-war area, all of which led to the ultimate development of PTSD. So when you're examining a patient for the extent to which the particular event or series of events led to the development of PTSD, what I'd like to ask you to consider is looking at the whole compilation of life experiences starting in childhood and then going to periods of time post-exposure, if you can get to the post-exposure phase. So how should stressful events be documented? This is a $60,000 question. It's not that easy to do. Many years ago, we developed something called the Combat Exposure Scale, which was one of the first scales to try to quantify how much exposure to combat did Vietnam theater veterans have. It was very simplistic, but it was a good sort of marker or ledger, frankly. But there are now much better ways of dimensionalizing the exposures. As there are scales available to help you dimensionalize things like torture, things like sexual assault, things like child abuse, things like domestic violence, these measures are now out there to help you quantify and provide comparative information against normative groups of people who've had similar or related experiences. There were, I'll just say, from the Vietnam era, many different kinds of scales. They needed to be re-upped for the Persian Gulf War I and then again in Persian Gulf War II. And I'll just say that Dan and Linda King and their junior colleague, who's now a senior colleague, Don Vogt, who have developed something called the Deployment, Risk, and Resiliency Inventory. Now, this is a measure of combat exposure, of the aftermath of battle, of the perceived threat and the life threat associated with these experiences, and then as well the difficult learning and living environment, living and working environment that people have experienced. This DRRI, the Deployment Risk and Resiliency Inventory, is a remarkably sensitive scale. It is much longer and it takes time to administer. Anything in life that is worthwhile, it takes time. But the DRI now has become the class of the field, trying to help us understand who goes on to develop PTSD and who doesn't. There will be a rash of additional studies coming from places like Minneapolis, Boston, San Francisco, Palo Alto, Los Angeles, and the like, San Diego, notably, that are using this to try to quantify exposures. I'll just do that. There are many ways of going about trying to classify and categorize and dimensionalize the exposures that you're dealing with. And if you're dealing with if you work in a rape crisis center, you need to look for the measures that help you there. If you're working in a domestic violence shelter, look for the measures that help there. And there are just some wonderful people who are doing remarkable work that I think can be of great help and use for you. Some of the classification issues that we've struggled with and grappled with are the standards in the field, content validity, to make sure we're measuring the range of symptoms. And it has really been my sort of insistence in our center to try to look more broadly at the constructs. Don't just look at the diagnostic criteria, which seems to be just a very common error made. Full utility analyses. We did presume right from the outset that PTSD was dimensional. At the time, we didn't know how to go about testing it, but I will show you here if this is visible here at all. This is taken from an article by John Rucho, Ayelet Rucho, and myself some years ago, looking at the Mississippi scale and the CAPS, and basically trying to do a taxonometric analysis, looking to see if PTSD was in fact dimensional. And not only did we find it across measures, across the populations that we were dealing with, there were subsequent papers coming from many different places in the country, excellent places who did work essentially confirming, for me at least until this moment, that PTSD is dimensional. It is not something that you either have or you don't have. Again, this audience would know this, but this is a common question that I get in various places where I sit. So issues of functioning and quality of life. I have a little bit longer, right? Yeah, 15 more minutes. Yeah, right. Okay, great. Thanks. So the issues of functioning and quality of life. Of course, as I mentioned in a slide earlier, functioning became very important in subsequent iterations of the DSM. How is somebody functioning? And it is in fact the case. Let me say this. I think I alluded to this earlier. You can have PTSD by itself. If you have PTSD by itself, typically you go on to do all kinds of great things in your life. You can be a great mother, you can be a great father, spouse, parent, etc. Work well at your job, etc. It's really when the symptomatology exacerbates and you begin to cascade down the hill like a snowball, and you collect additional diagnoses. And so the people who come forward in our center, in our clinic, for treatment of PTSD carry with them 4 additional psychiatric, and often multiple medical diagnoses along with them. So it's PTSD plus 4 in our VA medical center in Boston. That's been replicated at other places too that have given full SCIDs or mostly full SCIDs to their patient populations. And it's that which is related to, I think, this great disability that's often associated with PTSD. It's a disability associated with many different things. And this is just a study that appeared a few weeks back from one of our groups in Boston, suggesting that if you have PTSD and you have depression and you have a mild traumatic brain injury, that cluster, those 3, seem to have a much greater impact on the brain itself, looking at measures of neuroimaging, structural and functional MRI. So we do know at the most profound level, it seems to me, that the more conditions you have, the more likely it is that you will have disability. And so it becomes a very important matter to assess this side of the equation as well as that side of the equation. And so Brian Marks, some years ago when he first moved back to Boston, he was an RA of mine in 1989 to 91. And then about 7 years ago, he moved back to join us as faculty. And he, in the context of a meeting that we were having, he just came up with the idea that, it would be really great if we could have a functional impairment or a functional psychosocial functioning measure. And I sort of looked at him and I said, do you know there have been 8,000 people who have tried and failed at that? But he was pretty determined that he was going to try to do this. And the good news is, although the paper is not yet published, it's about to be published, suggesting that we can actually do this fairly well. The IPF actually is 80 items. Each of them is rated on a 7-point scale, 0 to 6. Again, the dimensionality piece. It yields a total score, but it also yields scores for 7 various scales. Romantic relationships, you're functioning as a family member, parenting, friendships, work, vocational, educational, and self-care. And these are the areas. And I'll just say that the preliminary data now with several hundred patients participating suggests that those patients coming forward for care who get the diagnosis of PTSD are really quite different from those people who do not get the diagnosis of PTSD. And you'll see here, just, if you will, just take the t-test if that's sophisticated enough for you, and you'll just see that these are differences across virtually all of these various scales. The education thing may not actually work for everybody because most people are already post-education when they are experiencing the war trauma that we study. And then I'll just say, finally, Brian felt that it was important to come up with a cutoff score for determining clinically significant functional impairment. And he worked for months trying to figure out what the best cut was and what to reference it back to. What was important enough that was happening in their lives that he could reference back. And so he now has a cut score of 41, essentially, and a half, that yields, I think, the best possible threshold for suggesting that somebody has serious problems in psychosocial functioning. I want to give you a sense of why I think all of this is important. Anybody in the room ever do a compensation and pension examination for the VA? Yeah, a bunch. Anyone ever do a Social Security evaluation for psychiatric or social? A bunch more. Yeah, so as you very likely know, while they don't pay that well, they are incredibly important things in the lives of the patient, in the lives of the public, and in our lives as basically people trying to comment upon the extent to which someone is experiencing disability. So in VA, we have something called service-connected disability, and it's often associated with physical injuries in war or illnesses or diseases that occur during military service. But in the very early 1980s, Congress decided that post-traumatic stress disorder was a disorder, was an injury for which people could seek and request compensation. And so over the course of maybe about 25 years, I was involved in trying to write best practice manuals for assessment in the context of these comp and pen exams, as we call them, compensation and pension exams. And I would write them, and they would be sent to every single VA in the entire country and sit on a shelf in the library, never, ever, ever to be opened by the clinicians doing these examinations on behalf of the country. Just to let you know that I think the current, if you were 100% service connected, the numbers are maybe about $35,000 tax-free a year. It's a significant amount of money. It's very important to the patients who need this money to support themselves and their families. But there's a lot of money on the line because it's basically an indefinite kind of pension for people. So we were challenged at some point, Brian Marks and I and a couple of other people across the country, from Minnesota, from Nashville, from Boston, from Providence, to look at the quality of these examinations across the country. And so I, being the sort of like sort of wise old guy, said, well, you know, you can't really stick a microphone in the room and evaluate how people do, because, you know, did you guys ever hear of the Hawthorne Effect? I mean, people will behave how they think you want them to behave when they're being monitored. Boy, was I wrong. Let me tell you what we found here. This is a remarkable thing. At the end of the day, we did put the microphone in the room. We did tell the clinicians, you know, we're going to see how you do and want to see how, you know, how you conduct your exams and whatever. And this is what happened. So let me just say, the overall concordance rates on service connection was not what I would call good. It was about 70%. So in other words, there was a lot of error in all directions, to be honest. False positives, true positives, false negatives, etc. And that is really just where the problem begins. Because, well, I mean, the background is a lot of people are going for service-connected PTSD disability. There's a lot of people complaining about it. You may see it in the New York Times, the Washington Post. There's a psychiatrist named Sally Satel, a psychologist named Chris Free, who are writing, Rich McNally at Harvard, who are writing about all of this all the time, without any data on the issue, to be honest. And so what we decided to do was to compare standardized and non-standardized examinations. In other words, we taught people how to use the diagnostic tests that we developed, the CAPS, and then we wanted them to use also the World Health Organization's Disability Adjustment Scale, which is probably somewhat familiar to many clinicians in the room. And we were interested in accuracy, costs, patient satisfaction, clinician satisfaction, and feasibility of doing all this. This is just really a slide suggesting what happens in comp and pen, but it's probably pretty obvious to you. The design was a cluster randomized controlled trial, 6 VA medical centers, standardized versus non-standardized. In other words, we trained people, and then we let people do what they did routinely, that they've been doing in some cases for years, if not decades. The standardization was the CAPS and the HUDAS. There were about 1,000 veterans who were eligible. We got written consent to do this from 400 of those patients. We got data that was clean and usable from 384 of these people, and they were from multiple eras. There were 33 examiners at these 6 sites who agreed to participate. And so the interesting part about it is, you know, there at the time of the study, there were 17 symptoms that constituted the diagnostic criteria for PTSD. And so among the people who were taught to use a standardized approach to evaluating PTSD, they did very well. But what was amazing to me, people who knew what we were doing, I mean, it was all fully open consent. What was amazing to me was that these people actually only asked 30% of the 17 symptoms. And they were essentially speculating on the other 70% of the symptoms in a compensation and pension examination that is of exceptional importance to the patient and to the country, to the community, who wants to help and support people, but wants to do so in the most appropriate, rigorous way. Just in case you thought it was just part of things, it was basically just about everywhere. If you were trained and you used a standardized approach, you did not just better, but you can see here, you did a ton better. So the notion here, this is completeness of the functional assessment, similar findings here. How you go about trying to assess the degree of disability if you don't ask any questions. I don't know exactly what people were thinking, but they weren't. Remember, these were 33 doctoral trained people, psychologists and psychiatrists, who did this, and they basically didn't ask anything about functioning. So, basically, we have a problem. So we have really, we've presented these data in many different ways and places. This now becomes an issue of implementation and dissemination of something that's very complicated to do. Trying to get clinicians across the country to do the same thing, to use the same instruments, or to use an instrument, or to use psychological testing, is a major, major challenge, for reasons that I suspect would constitute a wonderful discussion here. But it's so hard, with so much riding on this for the patients, with so much riding on it for the community. And yet, this is the kind of findings that we got. And these were, again, these were not surreptitiously obtained. So in any case, these, lots of things that are happening in the assessment diagnostic world, way more than I could possibly even cover here today. But I will say, I tried to pick out a few of the areas that I think we're going to be heading into soon in the area of PTSD. One is we've got to do much better in terms of culture. We do very, very well with European Americans, African Americans. We do less well with all the other groups in the country. Why? Because they're small in number, typically, that it's hard to aggregate data and get sensible numbers for comparisons. But we need to do better, which means we need to oversample. We need to study where the patients are located, for example, in Honolulu or in the Southwest, where there might be Honolulu, where there's a very large Asian population, Southwest, where there's a large Hispanic population. I think we need to do much more in the biomarkers. The Consortium to Alleviate PTSD, which I co-direct with Alan Peterson from the University of Texas Health Sciences Center, has a major component of looking at biomarkers for PTSD. You've already heard what I think. We'll get close. We're not going to have a litmus test. Generalization of tools for the OEF, OAF cohort, we need to do more of this. A lot of it's just about to come out in the literature, and the good news is all of the tools that we have work every bit as well on this most recent cohort of veterans as it did in prior cohorts of veterans. We need more work on things like the DRRI. The DRRI, Deployment Risk and Resilience Inventory, is very large, somewhat burdensome for people to take. We can abbreviate it. How might we abbreviate it? Well, certainly the use of item response theory and ways of going about trying to shorten things will be one major direction in the near term. If you have questions or issues about psychological assessment, let me encourage you, or about treatment, or about just general PTSD, let me encourage you to go to our remarkable website, www.ptsd.va.gov. It is an amazing, multiple award-winning thing that we've been doing since websites began, and it gets better and better every year and contains more and more information for patients, for clinicians, and the like. I can't thank you enough for the opportunity to come here to New York to speak with you, and I'm happy to take a question or two if we have time, John. Thank you.
Well, we have time for one really good question. Who has the best question? I see a hand back there. Please stand up and speak loudly. Oh, I thought I saw a hand. Yes, Ron Ganell.
Can you hear me? Yeah. Okay. So there's controversy in the field of mild traumatic brain injury and PTSD, with one of the issues being whether people who are knocked unconscious and do not remember the traumatic event, either because of post-traumatic amnesia or retrograde amnesia, whether they can actually have PTSD if they don't remember the traumatic event. And I'd be very interested to hear what your thoughts are about that.
Yeah, great, thanks. Thanks. Did you put that on? Did you put my lavalier on? Yeah, so a big quick, what if you don't remember the experience, okay? And what if you don't remember it and it was functional memory problem versus perhaps a physiologic memory problem? What I have found is that there is always a small subsection of the patients coming forward who really don't remember, whether it's for sort of the traumatic memory kind of problems that we know exist in PTSD and trauma, or whether it's because it was an automobile wreck and you hit your head and you were knocked unconscious for a period of time, or something like this. My view of it is that there will be people say, I really don't remember it, but people think I have PTSD, that kind of patient. But then there's another whole large group of people who actually sort of weave together the fabric of the story from what they have learned about the story. Many traumatic events, by the way, are covered on TV, they're covered in the local newspapers, they are widely discussed by family members. And so it is pretty remarkable how you can begin to weave together the story about what happened to you with some pretty fearful reactions to it. So what do I think? I don't think I'm the person who has the answer to this, but if you were to ask me, do I think it's possible for somebody who was knocked unconscious, doesn't remember the car wreck, but absolutely has PTSD to a car wreck, if you ask them what they have nightmares to and flashbacks to and preoccupation to, they will tell you it's about the car wreck. And then you say, well, how would you know? Well, because I saw the car in the dump or wherever they take the cars, and I just imagine what it was like. So that may be a sufficient explanation. It's certainly good enough for me. But I don't know that I have a firm handle on all of it. But that's a good question. Yeah.
Dr. Keane, I'd like to thank you for coming to SPA for this stimulating talk. We appreciate your time.
Thanks so much.